Hello, everyone. I'm Dr. Gary Severance with Henry Schein, and I want to welcome you to today's webinar on COVID-19, part of the YouTube video presentation. Today, we're very excited to have Dr. Reznik back to do live Q&A, and certainly you guys don't disappoint us with all the questions. So we've got a full set of questions, but we'll also take some, if it's not answered in the category, if you can put it in the Q&A section below, we'll try to get that. We'll break for some live questions as well. We have 4 categories today: personal protective equipment, patient screening, vaccines and vaccinations, and returning to normal. So if you have questions in those subjects, kind of wait till we get to that subject and we can better address that, and you'll see if it's already previously answered. Dr. Reznik, welcome, and I'll turn it over to you and we'll communicate throughout the program.
Thank you, Dr. Severance, and I really look forward to this because it's more interesting to know what your questions are as opposed to what I think you might want to know. So this is a great opportunity. This is just our disclaimer slide that shows up whenever we do one of these presentations. And the first area that we're going to look at is PPE, and I think that's a really great start. So have there been any changes to PPE in the dental setting? And I imagine that means at this phase in the COVID pandemic. And the answer is simply no. We still need to wear all your PPE. You still need to, if you're fully vaccinated, you still need to have on your N95. You still need to have on eye protection. You still need to have on the appropriate gown, the appropriate gloving. The way I'd like to really word this is we made changes several decades ago to deal with bloodborne pathogens. We now have an airborne pathogen that does have the ability to mutate. But we also have fabulous vaccines that are proving to be 95, 90% effective, and they're giving us a certain level of protection. But while we're in a setting where we are producing aerosols and we are in close proximity to those, our patients, the goal is to continue to wear your full PPE. At this point, the CDC has not changed their recommendations, nor has the ADA. Patient screening is really sort of interesting. And I'm going to answer these questions and put in a little personal experience I recently had. Should we continue screening patients prior to arrival for appointment? I think the answer to that question is still yes. Recent COVID exposure, temperature checks, etc. I think all those things are perfectly fine. When I make an appointment to go to the back doctor, I get these questions asked every time. And regretfully, over the last week, I have been there twice, and I will be there twice next week. And they have a way of dealing with it. And this is what happens. So I'm answering the second question as well. I was literally in my car driving home. Phone call came through. It was the neurosurgery office, and they were asking me the pre-COVID questions. And I was answering them. And on the third thing, I said, I've been fully vaccinated, and it happened quite some time ago. They asked me to bring in my card. And my first thought was I was put off. I mean, these cards are basically like gold. I don't have my card with me usually. It's usually, actually, to be frankly honest, it's in a safety deposit box at this point, should I need it for travel or whatever. But I went and took a picture of it. And the reason that they asked is that they're trying to do, or they don't call you each and every time about your exposures. So have you had a recent exposure, doing the temperature check? I still get temperature checked when I go there. They'll still maybe ask a question, but those phone calls are limited now. So I won't be getting those phone calls for maybe a diagnostic test I'll have on Monday. I won't be getting those phone calls on Wednesday when I maybe go for a small minor procedure, because now they have a picture of my vaccine card in their medical record. So do I think that you need to have this? No. But if you have a vaccination and you can scan the card and put it in the patient's record, then you can limit the number of pre-screening calls that you need to make, because you'll know that that patient has been vaccinated. You have proof of vaccination in the chart. Will that make any difference on how you treat that patient in the dental setting? And I hope your answer to that question is no. We still have to do all of our PPE if the person is vaccinated, etc. For patients and staff who won't get vaccinated, how do we navigate this besides pre-screening questions? Well, to be frankly honest, we're not, I can't say we're not. Getting 100% of people to be vaccinated at this point in time is out of the healthcare setting. Yes, we might expect it, but even then, there are going to be people who are hesitant about getting this vaccine in the healthcare setting. There's studies that have shown that, like, home healthcare nurses, for the most part, are in the group that are lowest getting vaccinated. People who work in a hospital or outpatient setting, like I do, are more likely to get vaccinated. But if you look at the total numbers, about 20% of the total population has been fully vaccinated as of today. About 25% of adults have been fully vaccinated, and about 57% of our seniors have been vaccinated. So we're going to be in a situation where there are a lot of patients that we see, I would imagine, for the upcoming rest of this year, that are not going to be fully vaccinated. Just like we treat every patient as if they have a bloodborne pathogen, we need to start treating our patients as if they're possibly carrying an airborne pathogen. So I think the way you would navigate that is just treat them like you would any other person. You're going to have on your N95s, et cetera, and we'll get to that in our PPE and some more PPE questions. So what about some live questions? What do we have, Gary or Dr. Severance?
Gary's fine. I just want to reiterate some of the things you said on the PPE. So nothing has really changed in regards to the CDC.
We're still in our full fit tested N95s. If you go from one brand to another, please make sure you get fit tested on the new brand. Eye protection is remarkably important. We've been doing that for a long time. And I will say, for the entire dental staff, one area that I find sometimes my staff is chairside, they always have on eye protection. It's in the infection control area that I'm always concerned. And so we really need to stress that for our staff people.
Great. A couple good questions just came in as well. And it relates to also another one we have. Going back to polishing, the use of Cavitron ultrasonic scalers. What are your thoughts on using them again with proper protection?
So I would say since August of last year, we have been using ultrasonics. We have been doing the full range of dental services that we have available at the Oral Health Center at Grady. And that's because I have my staff is fit tested for N95s. We have disposable gowns. We have surgical equipment. We have everything that we would need. I also have extraoral evacuation systems. I do believe in those quite strongly. I think when I've talked about them in the past, I have remarkable dental assistants at this program, many of which have served over 20 years. And I would do a procedure and look at my shield before COVID, and my shield would be covered with splatter. And so when we have these extraoral evacuation systems in place, there is no splatter. And if there is no splatter, there is no aerosol. So I think the whole goal is to maintain what you're doing. Make sure that you have high volume evacuation if you're using a Cavitron or ultrasonic scaler. Make sure that you have your fit tested N95 face shield and gown on. And I really do believe in the extraoral evacuation systems, because I think that, yes, high volume evacuation is 90% effective. That 10% is what I'm concerned with.
Great. And no difference whether the patient had been vaccinated or not.
As someone who has, I have access to medical records here, it's a little bit different, but it was someone who did work in the private sector during the very beginning of the other pandemic, HIV. Patients would come in all the time saying that they didn't have it because they knew that I treated and it wouldn't really make a difference. And so I just assume that even if they say they're vaccinated, it doesn't matter. Everybody has the potential to spread this disease, and it's not over yet. As much as as positive as I tend to be, you can look at some states. Michigan is really having a significant outbreak right now. It's that B.1.1.7 variant that is now the most predominant strain we have in the United States. And so therefore, some of their hospitals are stopping to do elective surgeries again because of capacity issues. So we're not through this. We don't know which direction it's going to take. So therefore, we really need to maintain all of those remarkable protocols we have put in place.
Okay, and this one I think may apply here as well as returning to normal. Recently, I think on Monday, information came out regarding the surface disinfection. Can we go back to magazines, pamphlets, office furniture, and others? What are your thoughts on that, or what is the CDC's direction?
Well, these would be my thoughts. When that study came out, and what it showed was that fomite transmission, or something that would have landed on my desk, for instance, the chances of seroconverting with exposure to a solid inanimate object are 1 in 10,000. So we wipe our waiting room chairs down in the morning like we did before COVID. We wipe them down at lunchtime like we did before COVID. Magazines are back. Pamphlets with patient instructions are back. Information about services that we offer are back. So our waiting rooms are literally turned back to normal. And I think that's a great thing. We want to now, do we still have the seating spread apart? Yes. Do we still have limited numbers of people in the waiting room at a given time? Yes. But can you have paper back in your waiting room? You sure can.
Great. I think we can go on to vaccines and vaccination.
There we go. Next up. I've been vaccinated. Can I stop double masking? So I'm going to sort of word this in a way that I heard. If the real world, our research studies have shown that our 2 mRNA vaccines are 95% effective. And then we look at real world data. What happens when we have people like you and me who are not part of that study, but maybe a part of a different study just where they're looking for asymptomatic infection? And what we found is that our fabulous mRNA vaccines at around 6 months are giving us 90% protection, which is remarkably good news. However, I want you to picture this and then put it in a way that I heard it explained to me, that if you were a firefighter and you put on all of your gear and you knew that it was 95 or 90% effective, that you might have an area that wasn't completely covered, would you run into that fire? Well, if it's your family or your pet, probably you would do it. But in most cases, you're not going to. You're not going to put yourself at risk. So to me, and from all the information we have at this point, you cannot stop your masking procedures in the dental setting, especially when aerosol generating procedures are being offered. What is the recommended time delay after the second vaccination to see emergencies in the dental office? I have to move that to see this. Well, I don't, okay. So what is the recommended time delay after the second vaccination to see dental emergencies in the office? Before we had vaccines, we were seeing dental emergencies only in the office. Then we sort of expanded out to some removable because it's not an aerosol generating procedure. There is no recommended time delay after the second vaccination to see dental emergencies. If you're only going to take, I don't know how you can only take patients who have been vaccinated. And even if that's the case, and they're really not doing asymptomatic transmission, unless you demand that they have their vaccination card and you have the date of the vaccination and you know how effective it is down the road. I think you just need to see emergencies as you've always been doing and don't really depend on their vaccination card. Their vaccination status does reduce our risk. However, the risk is still there. So it's really important for you to take all the precautions that you have been in the past. What should I do if my staff refuses to get vaccinated? I have educated everyone. I've got to try to move this again. Backspace. I'm sorry. what should I do if my staff refuses to get vaccinated? I have educated everyone. At this point, we cannot force people, at least in Georgia, to require vaccination. What we do require, I have to say, I have one staff person at this point who is scheduled for their first injection. You still have to follow all the protocols. I mean, I don't think it depends on your state work laws and things like that, which you would need someone who has a legal degree or an employment degree to answer. I think what you can continue to do is to educate. Not intimidate, but educate. Give the information showing that there really are no risks associated with the United States FDA emergency use authorization protocol. And I think because it's under emergency use authorization, it's very difficult to mandate that people get vaccinated. What is the best way to talk to patients who ask if every staff member is vaccinated? That question I find a tad troubling because my answer would be most members of my staff have been vaccinated. All members of my staff are going to take 100% precautions to make sure that you are not exposed. I don't think, in my opinion, I don't know how professional or how appropriate that question is. We are known for taking extraordinary steps in infection control. If you follow OSAP over the years, you know how we stress infection control and how there's an organization just built around this. If you look at some of that preliminary data that the American Dental Hygiene Association published, the percentage of hygienists who had seroconverted, the number was small because of our existing infection control protocols and the addition of our N95s and the extra steps that we're taking. So I would say that we are probably the safest environment for people to go to because we are protecting their health. We are ensuring that they have healthy outcomes. And I do hope that that answer is helpful. If a patient has been fully vaccinated, is it safe to use a Cavitron and polish? Again, the way we have to look at this is that we don't know who is fully vaccinated or not. And even if they are fully vaccinated, yes, the chances of them transmitting the disease are really minimal, if any. So yes, it's safe to use the Cavitron and polish. My patients all have the ability to get vaccinated and make appointments. In downtown Atlanta now, and the Mercedes-Benz Dome, I think they have 6,000 openings a day to get people vaccinated. So, but I don't want to discriminate against those that have not been fully vaccinated, because if you use the proper high volume evacuation, if you use extraoral evacuation systems, then it's safe to do. If fully vaccinated, do we as healthcare providers need to worry about being exposed to COVID positive patients and or family members? So if you're fully vaccinated as healthcare workers, do we need to be exposed about COVID positive patients? Again, that's the same answer that I've been giving about making sure that you have on your appropriate PPE and follow all of the CDC's guidelines. With the exception, they still say don't do aerosol generating procedures, and I don't agree with that. We've been doing aerosol generating procedures here for several months. As I've mentioned, we have had 0 cases, knock on wood, of any of my staff or myself converting to being COVID. As far as family members, you know, family is something different, but what we need to know is once they've been exposed or they're test positive for COVID, that they will form antibodies after a certain period of time. And so you're vaccinated, but still take precautions. Like I said, you're 95% vaccinated. That's what 95% immune. And after a period of 6 months, you're 90%. So help your family members get vaccinated. If they test positive, support them during this process. And then don't forget that a significant number of people who do test positive, who have asymptomatic disease, might have symptoms that go out, or mild symptomatic disease might have symptoms that go out for several months. And so we need to be wary of that and to make sure we're there for our family members. What do I say to those who say, well, they didn't die from COVID? With over 530,000 deaths, it is now the third leading cause of death in the United States. I wouldn't argue with the patient. I would do my best to say what the facts are. Yes, you might have been 85 years old and you might have had COVID, and that probably was your source of death. And you might have had coronary artery disease, and you might have had cardiovascular disease, and you might have been diabetic, but the source of death is what is put on the license, and it's COVID. Regretfully, this has been quite a bad pandemic. It's our once in a lifetime pandemic, even more so than the first pandemic that I've been involved in, because it only impacted a small section of our population. This pandemic can impact everybody in our population, all target demographics. So if they didn't say that, I fight those kinds of opinions with fact, and hopefully that will be of help. Can you please touch on any known plans or data for vaccinating age 12 to 15? Pfizer has been doing studies in this age group with their mRNA vaccine, and they have found that it is 100% effective. They are getting ready to apply to the FDA for emergency use authorization, with plans of getting full authorization, because what their goal is to get kids vaccinated before they get to school in the fall. So really, there are significant plans in place. We want to make sure that schools are safe for our children, for our teachers, for those that work in the school environment. So there are a lot of studies right now, because we know that teenagers, which really weren't so hard hit by the original variant or the original SARS-2 COVID, are being impacted by the B117. So we really are looking at that, and the data is looking great at this point. We're even looking at a trial that involves children ages 6 up to 11. That is a trial that is called KidCove. It's from the Moderna vaccine, and they're looking at different dosing levels at this point for our smallest and our valuable children. So there are plans and data for vaccinating kids ages or children ages 12 to 15, and I think that's wonderful news. Have there been any studies that have been done on vaccinations related to infertility? And that's actually a really great question, because that is one of the biggest myths out there. And it's one of the myths that are holding some people back from getting vaccinated. So, to be frankly honest, the US Center for Disease Control has basically stated that there is no evidence that people who are pregnant or wanting to get pregnant should not get the vaccine. There was a very positive statement on whether you're trying to get pregnant now or wanting to get pregnant, issued by and I am going to read this, the American College of OBGYN, the American Society for Reproductive Medicine, and the Society for Maternal Fetal Medicine. While fertility was not specifically studied in clinical trials, no loss of fertility has been reported amongst trial participants or among the millions who have received the vaccine since their authorization. And no signs of infertility appeared in animal studies. Loss of fertility is scientifically unlikely. We really have to stress that. That's the only note I have in my entire talk today, because I thought this was such an important question, and it truly needed to be related. We now have data that a pregnant woman who was vaccinated while pregnant literally was transferred antibodies in the placenta blood as well as breast milk. So it's actually positive and healthy for the child. Do employees who have already had COVID need a vaccine? And the answer is yes. We don't know how long natural antibodies will last. Yes, there are some studies out there showing that maybe one dose might be sufficient, but we don't have enough data to say that only one dose will be sufficient, but we definitely need to get vaccinated. The one group who've had COVID that you need to delay up to 90 days is if they were treated with convalescent plasma or monoclonal antibodies. In those cases, if they were treated with either the monoclonal antibodies or convalescent plasma, they would need to wait for 90 days before getting their vaccination. If you just had COVID and you didn't have any kind of treatment like that, it's time to get vaccinated. Hope that helps. And it's time for your questions.
Great. And we have some good ones again. One of the things that probably we've all heard about is concerns of post complications from the vaccine. Have you seen or do you have concerns about that?
Actually, no. The biggest things that we see with the ones that are approved, and I'll talk first about the mRNA vaccines, is the first day. First shot, maybe soreness in the arm. The second shot, you might feel tired, sore. You might have chills. You might run a small fever, and that goes away within a day or two. And that's just your body showing an immune response. It is actually not a bad thing. And then on the other side, if you don't have any of these symptoms, don't worry, your body is still forming an immune response. So that is also equally as important. Now, there is some new data out on the J&J vaccine. There was a clinic in North Carolina and another clinic, I can't remember which state. These are clinics that stopped using the J&J vaccine because they were having a few issues, and it was such a small percentage, but it was sort of fainting, was basically what I was hearing, or feeling dizzy. Now, if you look at the number of people who faint getting a flu shot, I would love to see the comparative data, but those two clinics have stopped. The FDA has not withdrawn its emergency use authorization, and we are still using the J&J vaccine presently.
Right. And then a follow-up to it is, do you believe there will be annual vaccinations? Because we've only got a few months of data, not years. Do you see this, or do you hear this being an annual occurrence similar to the flu vaccine?
That is a remarkable question, and one I wish I had one of the immunologists I work with or virologists I work with in the room with me right now. I could go upstairs and get one. To be frankly honest, I don't see this as a one and done. I'll be honest. The viruses thrive. They want to live. They want to survive. And to survive, if they're being blocked, they're going to try to figure out ways to mutate. And until we get the vast majority of our country covered, I think we're going and eliminate global travel. I think we're going to see variants that might break through. So already Moderna is looking on a vaccine for one of the more difficult variants. But presently, the vaccines that we're using in the United States are effective against the variants, but we don't know for how long. And as I began to talk briefly, in a 6-month study, what was 95% coverage in the lab, it ended up being 90% in real life data, which is great, but we did see a reduction. So as those titers go down, we have to look at the T cell component and those kinds of things, but probably we're going to have more than one vaccine.
Great.
So for those who are needle phobic in dentistry, I'm sorry for the bad news.
A very practical question. If the entire dental team is vaccinated, is it okay to eat lunch together?
It would be like a family, and I look at my dental staff as family. And so if the entire staff is vaccinated, now in my hospital setting, no, we could not do that here. They're still saying that you have to mask and do those kinds of things. But if I was in a private practice dental office, we were all vaccinated, I think lunch would be perfectly fine.
Good.
Especially if it's 2 weeks after that second shot. Let's
Okay,
at least be official on that.
And then I do know you lecture around the world on this subject as well, so you have no problem mentioning it. But specifically, which extraoral suction device do you use?
Well, I have invested in the Aegis Vac Station. I sort of like that device because of the size of the cone and the way that the high-speed volume and when we're using a high-speed handpiece and the way that the aerosol and the plume plumps out, it gets into the cone. So some of these devices that are out on the market have very small little areas to catch the splatter and aerosol, even though their suction power might be strong. And so I like the Vaccinations because it has a huge cone. It's going to catch everything that we miss on chairside. So that's the device that I like.
And of course, you get it from Henry Schein. Right?
Of course, I get it from Henry Schein.
One question, can we take off masks if there are no patients in the office? And I assume they're all vaccinated.
Again, that is up to each and every facility's protocol. Our protocol at our hospital, which in our outpatient programs is while you're on property, you have on a mask, unless you are eating or drinking or you're in a private office like I am right now. So I always side on the air of caution. And I think, like I made that comment about lunch, if everybody's vaccinated, so forth and so on, but I think that we really need to err on the side of caution and maintain our masking.
Okay. And then a question, anonymous question, but aerosol from an asymptomatic patient can still emit aerosol and could affect other patients. That was more of a question. I'm assuming you're having everybody wear masks in the office unless you're treating them, correct?
Everybody in my office has has masks and everything on. You can't, and one of the rules we have in the health system is you can't walk into a COVID positive room without eye protection, mask, appropriate masking, so N95s, et cetera. And our dental office, our present space is small. We're moving to a much larger facility in a few months. And so, yes, while you're here, you have your masks on, you have all of your PPE on, because asymptomatic transmission or pre-symptomatic transmission is driving this pandemic. So yes, like I've said, you have to treat everybody, whether they're vaccinated or not, because I think it's just too early to go on that vaccine. You must be vaccinated to come and see. I don't see that as being good for business. I'm going to be frankly honest. I don't see that. It reminds me of, I hate the expression back in the day, but with all this gray showing up back in the day sort of works, that dental offices would advertise, we've all been tested for HIV and we're negative. Well, that's good. What'd you do that night? What happened on that weekend? I mean, that's a point in time. So I would assume, just like here, everybody has a bloodborne pathogen. Everybody has the potential to spread an airborne pathogen.
And we know some states, when I moved from Texas, that kind of let go of the mask rule. And I don't know what they're doing in dental offices actually, but you would still recommend patients coming in because of the mix of different individuals in that office in close quarters, put on a mask if they're not wearing it otherwise.
Oh, for sure. But now there's a difference between walking a fine line here. There's a difference between a mandate which says you must versus responsibility, which says you should. And so I have faith in the people in my community, because I see it all the time, of people keeping masks on. We have never had a mandate here. And we are right now in one of those blessed low peak periods. Now, if you listen to the scientists on television, things that happen, it goes through a bit of a rotation, and then the next wave would be coming down here. So we are keeping an eye on that. But I don't have any patient in my waiting room that won't have a mask on. You cannot be in this building without a mask on, period.
Okay. Do loops count as appropriate eye protection, or does the person need goggles also?
Well, loops and goggles are hard. So it would be loops and a face shield. Loops don't do it. Loops are not, or glasses are not considered, protection. Loops are a form of glasses that are magnified. They're not considered protection. So there are face shields out there that do accommodate loops, and that's what we supply for our residents and our faculty.
Great. And Amy wanted to know, and I know you can amplify this a bit, it's still important for everyone to know that you still can get COVID-19 even if you're vaccinated.
It is possible. There are cases of where it's happening. Remember, it's not 100% protection. It is 95% protection after a couple of weeks, and everybody's different. Everybody's response, your immune response is going to differ by age. Your immune response is going to be different by maybe what underlying medical conditions you might have, or if you're immunosuppressed for whatever reason. So yes, we have to basically realize that nothing is 100%. Maintain your normal protocols.
You address this a little bit with your extraoral suction device, but there are other high volume evacuations like Relief, Dry Shield, and other devices that have come onto the market that really help the intraoral evacuation. But we do know that intraoral evacuation is 95% effective of getting aerosols while they're in the mouth. You're talking the extraoral suction devices as well, right? So there are a number of devices.
We use both.
Can aid that. Yeah.
My hygienist, because we're public health, we don't have hygiene assistants, and I get reminded of that a great deal by my wonderful hygiene team. So they do have the combination. They have the extraoral and they have the intraoral.
Right.
I've always said this, and my most important function at this point in my career is ensuring the safety of my patients and my staff. And so we have gone above and beyond to make sure that this is a safest possible environment to receive dental care.
Do you have specific products that you use or your hygienists use?
Our hygienists use the Relief system.
Okay, good.
And the Aegis Vaccination.
Great. What's the reason to wait 90 days after a monoclonal antibody treatment with COVID treatment?
Oh, that's such a great question. That's one of those I would probably need to get back to you on, but I think that it's probably having to do with amplifying the temporary antibodies that are in your system to treat the disease. So I think they want to form natural antibodies, your own antibodies, and then vaccinate. That would be my best guess. It could be wrong.
Okay, that's from Leslie, if you want to get back to her, if you know Leslie.
Leslie, if you send a no, we will get back to you, actually.
Yeah, absolutely.
We'll do that. I always call this Stump the Dentists, because Dr. Severance is on, and you win, Leslie. You're the first to stump me so far. I wish I could give you something other than to admit that was a great question.
Is it valuable to have a patient get COVID tested before aerosol generating procedures like scaling, periosurgery, crown prep?
In my opinion, and that is something I so wanted to do in phase one of this pandemic, was to do antibody rapid testing, but not so I would take the patients out of care, so I could get the patient into care, into primary care, to address COVID, or to inform them they need to quarantine at home or isolate at home if their symptoms aren't bad. Not to protect the staff, because I had already put all of my steps in place. Because again, antibody testing, and I'm looking forward to the saliva-based testing, because, well, anything that's in the mouth is our area. We should take ownership over it, which is why we have some valuable screening tools for hepatitis C and HIV that look at, combined actually, that look at saliva. So if we have some tests for the saliva antibodies, it has some use, some utility. But again, it's not whether or not you're going to do a procedure, because you should assume, until we have herd immunity, which is a ways off, and even then, that every patient could potentially be an asymptomatic carrier.
Great. Yep. So Leslie's getting back to us. And Leslie, maybe I'll mention it at the end too, but send us an email at webinars@henryschein.com. We'll make sure we get to that too.
Yes,
we'll
I'll
copy
come back
this as well.
No problem.
I think you can go on to returning to normal. We'll get back with you in a few minutes.
Okay. When is it safe for a staff member or patient to return to the office after they have been exposed or had a positive COVID test? So this is a great question. It used to be 14 days, then the CDC sort of put it down to 10 days. Actually, our hospital, if you've been exposed, no longer requires you to be quarantined at this point. If you have a negative COVID test 5 days after the exposure, then it goes down to 7 days. So I hope that information is helpful. It is on the CDC's website. They have updated this. It was 14 days for a long period of time, but they realized it put tremendous strains on our health system, on personal finance, on businesses, dental offices, et cetera. So literally they have reduced it down to 10 days. And then, of course, we want to monitor you for symptoms up to that 14-day period of time. Do I think that dental offices would feel more comfortable with their sales personnel that come into the office once they're vaccinated? I'm opening, as I mentioned, the cherry on my career is about 5 floors, 6 floors up right now. I have had to work very closely with my sales personnel, the people who have been involved in building this program. So as again, when they walk in here, they have on KN95s or masks, and it's perfectly fine for them to come in here. As a matter of fact, I need that level of expertise. I'm not a dental equipment expert. People from Henry Schein are, Atlanta Dental are, and other companies that might be out there. There are information that some of it I can get online and don't need to talk to a sales rep, but others I need them to come in here and explain things for me and then get trained on new devices and get trained on some new technology. So yes, I think dental offices should feel more comfortable letting salespeople in their office now, as long as they have on, one, they do hand hygiene, and two, they have on a proper mask. Can we start using the ultrasonics again? We have already addressed this, but I'm more than happy to address it again. We are still using ultrasonics here. We have those devices that I have mentioned in previously. I'm a little bit more hesitant. I know it's sort of weird about polishing because that stuff splatters all over the place, but we are doing limited amounts of that, but we are using the ultrasonic. My hygienists are a remarkably important component of our practice. And their job is keeping, one, affecting oral disease caused by periodontal disease. And two, once we have our patients healthy, keeping them that way. I don't want to burn my hygiene staff out or have them at the hand orthopedist because they're constantly doing repeated motion all day long and hand scaling. And so just to feel what hand scaling was like, I actually did a case last week and hand scaled from start to finish, and my hand was sore afterwards. And so I don't want to sacrifice my remarkably talented hygiene team. I think ultrasonics are fine. How important is air filtration during non-aerosol generating procedures? Again, air filtration is important for all procedures because we're humans. We cough, we sneeze. So yes, air filtration. Another thing I have invested heavily in our program is something that I do to make sure that I have a safe environment. So we had air filtration when we started doing our removable prosthetic program again. We did not have the chair side evacuators. If you remember early on, there was such a huge demand, you couldn't get them. And so I did have the air filtration systems, which made me feel comfortable doing non-aerosol generating procedures. So I hope that helps. How much free time do you allow yourself, and what do I do with it? That's an odd question. How would I answer that? How much free time do I allow myself? I'm a workaholic. I do try to take Saturday off, except during college football season. And then I'm working Saturday mornings, and I'm a football fanatic. And so that's one of the things I do with it. And on Sunday mornings, I will work before football. Once football is on, I'm watching football. That's just who I am. And yes, I do have a favorite team that may have won the Super Bowl last year. I also like to play with my dogs, my family, and I like to smoke food and be outside in the gardens. I think it's very important that we stop and smell the roses. That was a lesson I learned very early on in the HIV pandemic when there was so much death surrounding us all the time. And so not only did I learn to stop and smell the roses, I learned to grow the roses. So I actually like to garden as well. What are the future and present protocols due to COVID-19? If we're talking about infection control, I think we're there, honestly. I think that we have our necessary protocols in place. If we're looking at vaccines, there are new vaccines, new generations they're already working on. If we're talking about treatments, there are 2 or 3 companies who are looking at pill forms of medication to treat COVID. So just think about that, being able to take a pill for 5 days and you get over it. Now, my concern, I don't know what once you're infected with COVID and you do get treatment, what those long-term consequences will be, which is why try to avoid getting infected, because these asymptomatic or these mild cases of COVID that we hear about, up to like 30%, even more, are showing long-term signs and symptoms. And there's also a tremendous mental health toll. We already know there's a mental health toll, and I'm so glad to see that the experts at CDC and NIH are now talking about physical distancing. We are social people. We are social creatures. We must remain in contact. I haven't seen my work sister up in Boston in quite some time, but I make sure that I talk to her. I make sure that I talk to friends in different parts. The only thing I don't miss the travel associated with conferences, I'll be frankly honest, but I miss the people. And so we really need to do everything we can to get to some form of whatever our new normal will be. Will it be like pre-COVID? I doubt it. But will it be something that we all can enjoy and be around and maybe just get vaccinated once again? That's my hope and my wish. How long should we wait after aerosol draining procedures to seat the next patient? The guidelines were 15 minutes. However, we have shortened that period of time here because we keep the air filtration units on in between our patients. As soon as we clean the cone, we make sure the information's on. So it's basically the normal time you would do for your normal infection control. I don't throw one patient in after another. So that's not what I'm trying to get at. But I do think that the 15 minutes was based on no air filtration. It was based on no extraoral evacuation. And I do have all of those devices. I have a device, yes, Dr. Severance, that I got from Henry Schein, known as virus killers, that are sporadically in the program. So I feel that we're relatively safe. Our patients are masked until we tell them to open to begin the procedure, and we mask them immediately after. And don't forget eye protection for the patients as well. Since COVID-19 is transmitted primarily through air and not objects, is it okay to place brochures and other items back in our waiting room? And I have addressed that earlier, and I say go for it. But please do your normal, we have housekeeping that comes in. I'm blessed about that. But my staff supervisor, this individual, Sherelle Small Holloway, who I have worked with for over 30 years, she literally bleaches down with our bleach wipes the waiting room well before patients get there, and she wipes down all the hard surfaces on the entire floor because we are all over the top when it gets to infection control. So take all the necessary steps. The recommendations are 15 minutes. I'm not going to go against the recommendations, but I do think there are ways to shorten that if you have the proper equipment. So that's that question. Let's see. Are people using COVID as an excuse to avoid the dentist? So my answer to this question is going to be personal again. There are certain things that I don't like doing. If you know me, you might know I have a lot of hair. I don't like getting my hair cut at all. It's not relaxing. It's not something I look forward to. I put it off. I used COVID as an excuse until last week when I looked at myself on a webinar and I thought, well, dear Lord, can't the man comb his hair before he goes on a webinar? And so I used not getting my hair cut as an excuse. Imagine there's a significant portion of the population that doesn't want to see us. So are they using COVID as an excuse? And so I think we really need to use that, look at that as it's human nature. Well, oh, this is something I don't want to do, so I'll just wait until it's 100% safe. When I know that there was nothing that was going to occur at the hairdresser or barber's office that was going to put me at risk, I just didn't want to go. And to show you how serious I was about that, I also made an appointment for a procedure that I might be a couple of years behind on that I really don't like having done. So when will this end? That is a remarkably good question. And I won't say I will get back with you on that. We will have monthly webinars that we will do hopefully throughout the year. I don't have an answer. I wish I did have an answer. I think herd immunity will give us more information, but we have to get up to 70% or 80% of the population being vaccinated. And right now we're at 20%. So is it safe right now to go into your local grocery store without a mask? Not as far as I'm concerned. I've been fully vaccinated. Will I go into my grocery store, my pharmacy, the place that cuts my hair without a mask? No way. Do I say stuff to patients I see in the clinic who don't have their mask, they're wearing the chin mask or their nose is out? Yes, I will. Do I say something in Publix or your local grocery store? I'm a little bit more hesitant about that because I have heard of physical alterations breaking out. And after a couple of fusions, I try to avoid physical alterations as much as I can, but I sort of give them the eye. How about that? So, any live question time? And I see that we probably have some.
Yes, we do. And just probably the right time as well. One of the questions is, have you used a powered air purifying respirator, and did you like it?
I have not used the PAPR. The powered air purifying respirator seems a bit bulky for what I would want to do, but it does give you a little bit more breathing room. I think when it comes to that, you really need to find the right kind of, I think people are using those because they're having a hard time breathing through whatever N95 they're using, which is one of the reasons I think that the health systems switched to the Halyard Fluid Shield N95s. And these actually offer more room to breathe. My worst asthmatic staff member can wear this chairside and breathe. And so I think that that's a better answer, but I have nothing against them. I think they're wonderful devices. I would probably prefer the full shield as opposed to the partial shield.
Great. And Linda's got a few questions that, if you don't mind, I'll try to tackle on some of this.
Oh, I would greatly appreciate some help.
Air filtration, is HEPA adequate? The CDC recommends a HEPA filter. Again, airflow, and you have to make sure the air goes through it to answer that question of effectiveness. Questions about UV. Does it work in these units? One of the things about UV light, you have to have dwell time, so it has to be powerful enough, the UV. The air has to stay near it for some time and be close to it. So a lot of variables going on with AV or UV. You just don't want the air flowing as fast as it can. It has to have some flow time. But there are some units like the virus killer technology, the JADE unit uses UV as an additional route to disinfection.
Gary, as does the Vaccinations.
Exactly.
Vaccination actually has HEPA filters, charcoal filters, and it has a UV filter at the bottom.
Yep. Difference between true HEPA and medical HEPA. It's just a rating on HEPA filters. Most HEPA filters, I think, get 99%. Medical are at the upper end. They're called true, or they have other names to it too. It can go up to 99.97. And then one question about the jade unit. So Barry has a jade unit in the room. They fog the room with hypochlorous acid and close the room for 15 minutes. Is this overkill?
You're asking me that question? I think that fogging probably between patients might be a bit much. Could you go over what he has again?
Yeah, the jade unit, which has HEPA filters, charcoal filters, good air filtration. Again, it means about looking at the air in your room. Is it all going through there? We've had some questions previously on hypochlorous acid. It's on the EPA list. However, no of the government regulations, EPA or CDC, have recommended fogging, although we know the airlines do it, the grocery stores do it, and a lot of people do the fogging. So I don't think there's any harm in it, but there's nobody formally recommending it as well. And the CDC, I think, did take off the 15 minutes, as you mentioned as well. And maybe there's no possible way to do overkill, but
yeah, I don't believe in overkill when it comes to patient safety.
Right.
Patient and staff safety, you do what it takes.
Yeah.
I probably have overkill in here, but that's perfectly fine because I know that those that I have the opportunity to serve and those that work with me, they're safe. And that's what's important.
Deborah wanted to make a point, I think, on when is it safe for a staff member or patient to return to the office? She mentioned that it may be state by state. Michigan had it at 7 days, but now have extended it to 14 days. So everybody may want to check with their state on that.
And I think that's important too, because right now Michigan is having, like Florida, these outbreaks tend to follow you, Dr. Severance. Michigan and Florida, and I think the 3 other states are accounting for almost half of all of the new infections we're seeing right now. And so, yes, when you have an outbreak, you're going to change your requirements. But remember, you can get tested 5 days in after an exposure, but follow your state rules. State rules always win at this point. The CDC can only offer recommendations.
Linda has another question. Linda, my air filtration, Honeywell, has carbon pre-filter. That's primarily for odors and VOCs, and a true HEPA, no UV. Calculated air that turns over is 12 times per hour. That's at the high end of what they're recommending, the HVAC systems are recommending, so that sounds good. Again, even though you have the air turnover, it's where the air is going, so make sure all the air goes through that system. UV is not required. I think with the carbon filter and the true HEPA, you're catching most of the particulates at that size, and turnover seems nice in that. There was a question also on air turnover that you can easily calculate. If you're not doing any aerosol generating procedures, or very few, like an orthodontist office, typically like in a medical exam, HVAC systems or the organizations recommend 6 to 9 on a medical exam room. There are no formal regulations on dental offices and areas, but certainly if you're not having a lot of aerosol. Again, I think in early discussions with Dr. Reznik, certainly somebody could cough or sing or talk loud, and there you have an aerosol generated procedure. So the more you can get, but still making sure all of the air is flowing in. And then from our time, we're hitting it just right. Kim has a question. Is it appropriate to ask a previously positive COVID patient with an ongoing cough to have a negative COVID test prior to appointing them?
The answer to this would most likely be no. There are a lot of people who have had symptomatic COVID and you test them later on, they're going to test positive because they have non-infectious viral particles still present. And we do know that there's this thing called long COVID or long haulers, where people will have symptoms. I've mentioned previously, I talked about some of the neurologic symptoms, and there could have shortness of breath. It could be coughing that goes on for a month or two. So again, if you take all of your appropriate precautions, it's safe to treat that patient.
Great. I know Adam will be very happy because we finished right on time. Helene wanted to know that if you don't get back to her, she's going to be driving to Atlanta to see you. And everybody that has any questions that want to continue or suggestions or ideas for future episodes, please let us know in dentistry in general or this series. Let us know at webinars@henryschein.com. And please subscribe to our YouTube page by clicking the subscribe button below. That way you'll get notified when all of these exciting webinars are coming your way. Thank you so much for attending. Dr. Reznik, it's always great to see you. Everybody have a great Friday evening and a good weekend.